Hello and welcome. Today we're diving into a condition that affects the heart's protective layer, acute pericarditis. This inflammation can cause significant discomfort, and understanding it is crucial for timely intervention. Join us as we explore the causes, symptoms, diagnosis, and treatment options for this important cardiac condition. So, what exactly causes acute pericarditis? The etiology is quite varied. Viral infections are the most common culprit, with viruses like Coxsackie virus and echovirus leading the charge. Bacterial infections, though less frequent, can also trigger pericarditis, especially in cases of pneumonia or sepsis. Fungal infections are rarer but possible. Beyond infections, autoimmune diseases such as lupus, rheumatoid arthritis, and scleroderma are significant contributors. Other causes include chest trauma from injuries or surgeries, radiation therapy to the chest, certain medications, kidney failure leading to anemia, and even cancer spreading to the pericardium. In some cases, the exact cause remains unknown, referred to as idiopathic pericarditis. To understand the impact of acute pericarditis, we need to delve into its pathophysiology. The pericardium, a double-layered sac surrounding the heart, becomes inflamed. This inflammation leads to the accumulation of fluid, cellular debris, and inflammatory cells within the pericardial space. This process directly irritates the pericardial layers, triggering chest pain. Additionally, the increased fluid and inflammation can restrict the heart's ability to fill properly, reducing cardiac output. In severe cases, this can lead to cardiac tamponade, a life-threatening condition where the heart is severely compressed, preventing it from pumping effectively. Now, let's look at the epidemiology. Acute pericarditis affects individuals of all ages and backgrounds, but it's more commonly seen in men aged 20 to 50. The incidence is estimated to be around 27.7 cases per 100,000 people per year. It accounts for approximately 1% of emergency room visits for chest pain, highlighting its clinical significance. People with underlying conditions such as autoimmune diseases, kidney failure, or cancer have a higher risk of developing pericarditis. The signs and symptoms of acute pericarditis can vary, but the hallmark symptom is sharp, stabbing chest pain. This pain is often located in the center or left side of the chest and is typically aggravated by breathing, coughing, swallowing, or lying down. Leaning forward can sometimes relieve the pain. Other symptoms may include shortness of breath, fatigue, a dry cough, fever, and palpitations. Some individuals may also experience referred pain to the shoulder or neck. It's important to note that these symptoms can mimic those of a heart attack, so prompt medical evaluation is crucial. Diagnosing acute pericarditis involves a combination of physical examination, patient history, and diagnostic tests. During a physical exam, a doctor might listen for a pericardial friction rub, a scratching or grating sound caused by the inflamed pericardial layers rubbing against each other. An electrocardiogram or ECG is a key diagnostic tool, often showing characteristic changes in the heart's electrical activity. Chest X-rays can help identify any enlargement of the heart or fluid accumulation in the pericardial sac. An echocardiogram, which uses ultrasound to visualize the heart, is invaluable in detecting pericardial effusion or fluid buildup and assessing its severity. Blood tests can also be performed to look for markers of inflammation, such as elevated C-react protein (Rp) and erythrocyte sedimentation rates (ESR). In some cases, further imaging like a CT scan or MRI may be necessary to rule out other conditions or to visualize the pericardium in more detail. Acute pericarditis is generally classified based on its duration and the presence of complications. We primarily distinguish between acute pericarditis, which has a sudden onset and lasts less than a few weeks, and recurrent pericarditis, where episodes occur after a symptom-free interval. Further classifications may include constrictive pericarditis, a chronic condition where the pericardium becomes thickened and rigid, impairing the heart's ability to function. Effusive constrictive pericarditis is another type, characterized by both fluid accumulation and constriction. Understanding the type of pericarditis helps guide the treatment approach and predict the prognosis. The primary goals of treatment and management are to alleviate pain, reduce inflammation, and prevent complications. Nonsteroidal anti-inflammatory drugs, or NSAIDs such as ibuprofen or indomethacin, are often the line treatment to reduce inflammation and pain. Colchicine, an anti-inflammatory medication, is frequently added to NSAIDs to further reduce inflammation and prevent recurrent episodes. In cases of severe pain or when NSAIDs are not effective, corticosteroids like prednisone may be used, but these are typically reserved for refractory cases due to their potential side effects. If the pericarditis is caused by a bacterial infection, antibiotics will be prescribed. For pericardial effusion, observation is often sufficient, but in cases of cardiac tamponade, pericardiocentesis, a procedure to drain fluid from the pericardial sac, is required. In rare instances of constrictive pericarditis, surgical removal of the pericardium known as a pericardiectomy, may be necessary. While preventing acute pericarditis entirely can be challenging, there are steps individuals can take to reduce their risk. Practicing good hygiene, such as frequent hand washing, can help prevent viral infections. Prompt treatment of underlying conditions, such as autoimmune diseases and kidney failure, is crucial. Avoiding excessive alcohol consumption and maintaining a healthy lifestyle can also contribute to overall cardiovascular health. In some cases, vaccinations against certain viruses, like the flu, may indirectly reduce the risk. The prognosis for acute pericarditis is generally good, especially with prompt diagnosis and appropriate treatment. Most individuals recover fully within a few weeks to months. However, recurrent pericarditis is a significant concern, affecting up to 30% of patients. Cardiac tamponade is a rare but potentially life-threatening complication, requiring immediate intervention. Constrictive pericarditis is a chronic condition that can lead to significant disability if left untreated. Recent research has focused on identifying biomarkers to predict recurrent episodes and optimizing treatment strategies to minimize recurrence. Novel anti-inflammatory therapies are also being investigated to improve outcomes. Furthermore, studies are exploring the long-term cardiovascular health of individuals who have experienced acute pericarditis, aiming to understand any potential residual effects or increased risk of future cardiac events.